courses and give you this one, but then you have to give it to the presenter.
Yeah, that's all right. No problem. Hello, good evening. Good evening, welcome back. If you guys could start taking your seats, please. We will launch into the evening trauma session, and then you'll be able to get to fondue on time. So, in terms of your fondue, it's at 8 o'clock upstairs, and there was also going to be a DJ. Okay, so good evening and welcome back. So, as you know, I work for London HEMS and the trauma service in London. And one of the great privileges of that is the patient group that we go to, but also being able to work with some exceptional individuals. And hopefully the mic will sort itself out in a second. Yep. The privilege of working with some fantastic individuals, and these are people that push me to be better every day, because when you work around people like this, then you really question what you do, you question your practice, and you try and improve your practice. So I'm going to hand over to them to run this session, and they are a fantastic bunch. So I was going to tell you a little bit about them. So just in no particular order, on the left of me is Samy Sadek. He's an EM physician, and he's been with HEMS for over 10 years. Zane Perkins is a world-leading trauma surgeon, and he's been with us for almost even longer, actually. I think it was back in 2010, I think I first saw you up there. Mike Palmer, who's a paramedic, so he's the one that means that we've got Welsh in the title as well. So he's actually English, by the way. He's only pretending to be Welsh. But he was a London Ambulance Service hazardous area paramedic and a regular paramedic with the London Ambulance Service, and then came and worked with us for a couple of years. And now he's gone on in his career to train as a critical care paramedic with the Welsh Air Ambulance. We've got Joe Steer, who's a current London HEMS paramedic. And finally, Robbie Lendrum, who's a cardiothoracic intensivist and anaesthetist. They're going to talk to you about hemorrhage, but I'm going to hand over to them.
Hello. Thank you, John, for the introduction. I'm Sam, as John said, and I'm going to basically introduce this session. We're going to kind of hammer you with information for a couple of hours, but hopefully not just hammer you with information. We're going to ask you some questions. We're going to get people engaged and interacting, and I want us to discuss as much as listen and learn as we go. And my job here is to introduce the session. You're going to hear a lot of science and data and intricacies around hemorrhage and exsanguination and trauma in the next couple of hours. And really, I mean, we couldn't even agree on the title of our session, but I've decided to call it this. And the point is that we want to try and challenge ourselves on what we think happens when someone is bleeding to death or exsanguinating or has a cardiac arrest, a traumatic cardiac arrest, or whatever you want to call that, but particularly focusing on exsanguination I want us to challenge ourselves. I want you to challenge us, and we're going to challenge you, and try and keep it interactive. The clue is in the title as to what we think we're learning as we go, straight to the heart of the matter. I thought that was quite clever. No one else agreed. But the point is the word heart is in there, and we're going to keep coming back to that as we go. My other challenge is to try and keep to time. Now, sadly, we wrote our slides. Well, I certainly wrote my slides before hearing Ross talk, so he might have some real-time feedback for us at the end. But we are going to try and keep it interactive, so there's a lot of discussion to do. So why am I standing here in front of you? Well, everyone has a disclaimer at the start of their talk, and it's usually something a bit more highbrow than this. My only disclaimer is that I'm not a scientist. Clearly, I'm not a scientist. But I do work at the Royal London Hospital. I work in a major trauma centre in London and on an air ambulance that serves 10 million people in London. So I get exposed to a lot of trauma. I don't really see myself as a clever scientist, but clever or not, I see a lot of trauma, and I get frustrated by things over the years. I've been there, like John said, over 10 years now, and I am starting to get sick of seeing people die of conditions that we think we should be able to treat. And that's what we're digging into as we go. Why are these people dying when we think we should be able to save them from exsanguination? And what are we going to do about it? And we're just going to try and bring you along with the journey that we've been on over the last few years, challenge what you think and hear what you have to think about what we have to say. Now, for me, I like to tell stories, and I think it's easiest when we're talking about all this science and data and some quite complex physiology to think about real patients. So I'd urge you all to think about real patients that you've seen along the way, and I'm going to tell you about real patients that we've treated along the way. Now, we were here last year. So for those of you that were here or saw us last year, we talked about hemorrhage, and we did talk about some of the weird physiology that we were noticing as we dug deeper into exsanguination and death in the early phases of trauma. And we're going to try and now continue that story and give you some data to back it up, or to put a bit more meat on the bones. We've got, these guys have pulled out some amazing data from years worth of major trauma patients. We're going to show you some, not quite evidence, but physiological kind of proof of concept from some of the real physiology from real patients that demonstrate why we're thinking what we're thinking about why these patients die. And like I say, I like to tell a story, and of course we have to anonymize our cases, right? So I can't show you the real faces of the real patients, so I've given you pretend faces. And this, do you remember this guy? This is the lovely Robbie Lendrum. He's sitting there looking at me now, suspiciously, nervously, and rightly so. Because Robbie's going to star in the story, right? Robbie's going to star in the story of what happens when you bleed to death. And if you remember last year, this guy was a skier. We talked about a skier who was crashed into by this idiot on a snowboard. You know what snowboarders are like, man. They don't do things that you expect them to do, and they come crashing across the piste. They try and do jumps. They get it wrong. They smash into you. And this guy smashed this guy's spleen really badly, and it was torn off its arterial supply, and he was bleeding to death. And we described the physiology, and we described how we had to take extreme measures, and we all went through it together, right? We took extreme measures, and we just about saved his life, just, with very extreme measures. Now, you would think, after going through such a horrific injury and having his life saved, you'd forgive and forget, right? You'd get over it. You'd be like, do you know, I see life in a different way now, and I'm glad to be alive. But it turns out, some people, when they have a couple of beers, they don't always forgive and forget, and some people carry a burden, and some people still carry blame. And this particular pretend Robbie got a bit aggressive in the pub, and before we knew what was going on, he pulls out a knife and he stabs this guy in the abdomen. Straight up stabs him right in the middle of the abdomen. And we're like, what the? Why'd you do that? It's pretend Robbie. It's not real Robbie, okay? I promise you. It's not real Robbie. No HEMS clinicians were harmed in the making of this presentation. And Robbie doesn't stab people, I don't think. But what I want to do is talk through what happens to this look at this poor innocent snowboarder. What happens to him as he goes through the phases of his exsanguination or his trauma, and ask you to tell us what you think, right? And I want you to think through these questions as we go. So when he first gets stabbed, you're actually right next to him in the pub. You didn't expect it. No one expected it. I mean, why would you? But he gets stabbed in the abdomen. And he's angry. He's really angry. And everyone's trying to help. And he's like, back off. Leave me alone. I can't believe he did that. What on earth is wrong with you? He's swearing. He's shouting. He just looks really angry, right? What's wrong with him? I'm going to make you answer, by the way. We're not allowed to sit quietly because we haven't got much time and we're going to have to not run over time. So someone shout out to me and I'll shout it through the mic so we all hear. What's wrong with him now? Is there anything wrong with him or is there nothing wrong with him? Stabbed in the abdomen, get off, leave me alone. You're all a bunch of...
Might be angry, might be in shock. This might be early shock.
Okay. Yeah. So we've got angry, shock, and drunk. It might be all three. Okay. Why do you say it might be shock?
Mental status alteration. Agitation.
Yeah, okay, yeah. So we're talking minutes. This is like a minute or two after it's happened, right? What does he need? Does he need anything now? He looks all right. He looks just really angry. Does he needs another pint, maybe? Does he need anything else? Come on, anyone got an answer? Okay, an assessment, all right? Anyone think he needs anything else? Sweet, all right, so you want to get him to hospital quick. Whether we're in the mountains or whether in the city, does it matter to you? Yeah, okay, yeah. All right, cool. So, and why are you saying that? He looks fine. Why are you saying that? Well, we're giving a talk about exsanguination, aren't we? So, yeah. But yeah, like, I'm condescending you. I'm very aware you're a very senior bunch of clinicians, right? And I'm trying not to, like, totally condescend everyone. And we all know that penetrating trauma in particular can catch us out. And you can appear fine 1 minute and you can die the next minute. And we're going to dig into why that happens. But yeah, I think we all agree, get him to hospital, right? And in fact, the point is he doesn't need anything. He just needs to move to hospital at this point. So how long has he got until he gets sick and does something else? If you were guessing? If I'm going to tell you a story of someone that bleeds to death, how long is it going to be? I mean, I've only got about 2 or 3 minutes left, so we've got to be quick. Huh? Someone says 2 or 3 minutes, because that's all we've got left. Who said an hour? Someone said an hour? Less than an hour. Okay, all right. Okay, does he need anything extreme at the moment? This is an extreme conference, man. We're all talking about extreme medicine. Does he need anything extreme or not? No, he just needs to go. I mean, he might need a helicopter, I suppose, but that's it. He needs to go. Okay, oops. So as you're there with him, watching him, and some clinicians arrive, you know, maybe a helicopter does come if it's in the mountains, but, you know, clinicians arrive, they start to do some obs, and they start to assess him, and you start to notice, actually, he's looking quite pale now. He's changed. And when you look really closely, his lips are really pale. His gums are pale. He's starting to say, I'm thirsty. He does want more beer, but he's really thirsty for anything. Doesn't even matter if it's water. And he's getting agitated now, and actually, then he starts to go quite quiet, and he's starting to breathe quite deeply and quite quickly. And someone puts a blood pressure cuff on his arm, and it says a blood pressure of 90. What's wrong with him? Okay, what kind of shock? Hemorrhagic shock. Does anyone think he's in any other kind of shock? Yeah, it could be a tamponade, couldn't it? It could hit the lungs, cause a pneumothorax, could cause all sorts of things, right? Okay, but he's starting to look shocked. What does he need now? What kind of resuscitation? So someone has said resuscitation. Well, tell me what you mean. It's fine, you can say whatever you want. We're all safe here. Say what you think. Okay, you want to give him blood, all right? Does anyone, hands up in the room who wants to give blood? Okay, hands up who doesn't want to give blood. There's one or two, few of you don't want to give blood. Someone who said no, why not? Go on, I'm going to point you in the blue coat. You put your hand up. Okay, you don't think he needs it? All right. Does he need anything extreme? Quick, yes or no? Trauma, we got to think fast. Why? What does he need? How? Say that again. Okay. So he's saying Roboa. There's a gentleman in the audience. Are you saying that because it's me and I'm a bit like we've already decided that I quite like balloons? Is it, huh? Is that why, or is it because of something else? Yeah. Okay. I mean, it's fine to say no. He just. All right. All right. As you're thinking about all this, he pulls his mask off. He says, "I can't breathe. I can't breathe." He turns. He vomits. He poos his pants and he passes out. His eyes roll back. What's wrong with him now? Of what? Of what? Of exsanguination. Okay. Does anyone think he's dying of anything other than exsanguination? Yeah, okay. Yeah, okay. Yeah, we said it's an abdominal stab, and someone in the audience has said it could still be a tamponade, it could still be a tension, and that's right, okay? But a lot of us think he's exsanguinating. We'll come back to these questions again in a minute, and I just want to show you his obs. Someone puts this monitor on him. Shout out, what do you see? Tell me what's important about these obs. He's not tachycardic. Does that worry you? Anyone else see anything that is important? There's no temperature on there, sorry. Blood pressure's low. Huh? Who said what? Low diastolic. What does that mean? Loss of compensation. Okay, so someone is saying his diastolic is low and therefore he's not compensating. Okay, we'll come back to that. Anyone else? Final thoughts on the obs? He's hypoxic, okay. And when you look at him, you kind of can't work out that there doesn't seem to be anything wrong with his chest, but that is what it's saying on the monitor. So we'll come back to that. This was my guess, right? This is my last slide before we go on to my colleagues. This was my guess at what we were going to say in answer to these questions. And I think we were pretty much on where we most of us thought he was bleeding. Of course, we need to exclude a few other pathologies that are important. What does he need? I think most of us said he needs blood. I mean, we didn't specifically say he needs an operation, but everyone seems to want to get him to hospital, so that's cool. How long has he got? Well, I didn't really know what you were going to say, whether people were going to talk about his clinical signs like his pallor, his agitation and his thirst, or whether we were going to be more concerned about his obs and the numbers on the monitor, or whether people were going to tell me about data and what the survivability is and how many people in this clinical state die on a national or international scale. We can come back to that again at the end. Does he need anything extreme? Well, obviously someone shouted out Roboa, maybe because it's me and us talking, or maybe because that is what he needs. We'll come back to that again at the end. And no one's mentioned thoracotomy. Did anyone want to do a thoracotomy when he rolled his eyes back and went, I'm going to die?
In the pub?
Yeah, in the pub. Yeah? Go for it. Pass me the knife and fork, man. Let's do it. Yeah. Yeah. Does anyone not want to do it in the pub? Good question, Stacey. Stacey's asking if he's got a pulse, and I'm going to say to you, at that point, actually, no. It definitely can't feel a radial, and you're feeling here, and you're like, oh, don't think so, I don't know. And he's like, oh. Anyway, we better move on, because I'm just going to do weird faces at you all day. So, yeah, okay, so you want to give blood and get out of here. All right, cool. I just want to pose the last question, which is what are we going to do after whatever it is that we do in the pub, in the helicopter, on the way to hospital, right? What's next? And I kind of thought if I had time to ask you that in detail, most of us would talk about damage control surgery and intensive care to support his organs and get him through the rocky road that's ahead. Does anyone disagree with that? Come on, someone disagree. No one? Okay, cool. I'm going to pass you over to the experts now, who actually have some data and some science to share with you. And we're going to come back to some of these questions at the end.
Right, hi everyone, and great to be back here again this year. Thanks for having me. Yes, I'm a trauma surgeon at a busy trauma center in the UK, and I also work on this helicopter. And I'm going to talk to you about the place of resuscitative thoracotomy in pre-hospital care, loosely related to what Samy was telling you about, but it all come together after all the talks. Now, I'm in a unique position that I do this procedure in the operating theatre, in the emergency department, and in the pub. And I have my own thoughts on it and opinions, but I'm not going to give you those today. I'm in a quite unique position to actually share with you some really high quality data that we have. So my aim is to really talk you through a big data set that we have at London HEMS on this procedure, and try and just get you to understand traumatic cardiac arrest and how this procedure might fit in a little bit better. As with any creation of a big high-quality data set, there's been a lot of people involved in putting it together over many years. So I do want to acknowledge all the huge effort that's gone in, and I realize that I'm just in the nice position of showing it to you. Anyway, we'll start off with this. This is our London's air ambulance team treating someone in traumatic cardiac arrest. And actually, this whole talk is about traumatic cardiac arrest. Certain things about, so about 1 in 10 patients that we see on London's air ambulance are in traumatic cardiac arrest, and that's about 4 or 5 people a week. So it's common, okay? It's not as common as medical cardiac arrest, but this is a common cause of cardiac arrest, and invariably it's a child or a young, otherwise healthy adult. And looking at this team here, so this, they're treating a young man. He has been stabbed in the chest, and he's got a cardiac tamponade, and he's in cardiac arrest. And they resuscitate him with a pre-hospital resuscitative thoracotomy, and he makes a full recovery, fully neurologically intact. And the really interesting thing about this is this little half cut-off date down there. For those that can't see it, it's Christmas Eve 1993. Okay, so that's just about 30 years ago. And this was the very first, this actual photo of the very first survivor that London's HEMS had from a thoracotomy. They've been trying it for a few years prior to this, had a lot of criticism, and this was the first man to make a full recovery. And since then, we've advanced the procedure that we do, and we regularly get good survivors. But the interesting thing is, this has been 30 years. All of us in this room treat traumatic cardiac arrest, and I think you'll all agree that we still don't know what the optimal treatment is for someone in traumatic cardiac arrest, especially if we compare to like medical cardiac arrest. Everyone knows exactly what to do. How we treat them in London is different to how these patients get treated in other cities in the UK. It's different to how they get treated on the continent. It's different to how they get treated in America. And when you treat people different, you're going to get different outcomes. So variability in treatment, variability in outcomes. And really, I think the reason behind this, the real crux of the matter is there's not any high-quality data to inform us on what we should really be doing. A couple of years ago, the European Resuscitation Council brought out a new guideline on the treatment of traumatic cardiac arrest. And they completely acknowledge that there's very little high-quality data to base this algorithm on, and that a lot of it is opinion and the such. But this is a good algorithm, and particularly, they make 2 really important points. Firstly, that the treatment of traumatic cardiac arrest is different to the treatment of medical cardiac arrest. And then more importantly, the prime priority of the treatment of traumatic cardiac arrest is to treat the cause of that arrest, okay, to go straight for the cause. And they make that very clear. And we all know the potentially reversible causes: exsanguination, cardiac tamponade, tension pneumothorax, and hypoxia. They do suggest that thoracotomy might be needed to treat tamponade and exsanguination. And again, the data, there's a systematic review that this guideline is based on pre-hospital thoracotomy. And in total, they could only find 21 papers that described that procedure being done pre-hospital, and that was a total of 280 about patients. And there's obviously quite a lot of duplication in all those papers. So there's less than 280 cases reported in the literature on which to base this step. So whenever you have very little data and lots of opinions, you're going to get lots of controversies and lots of uncertainties. And I want to try and tackle a few of those with our data set today with you. So the first one is this all futile? Secondly, if it isn't futile, then what is the time window of having an effective intervention? And how do we identify patients that are in that window? Thirdly, is this something that should happen pre-hospital, or is this something that we should rather put all our efforts into getting that patient into a hospital to have it? Don't forget, there's a huge amount of effort to try and offer this procedure pre-hospital. Equipment, training, ongoing training, getting there in time. It's a tremendous amount of effort. So should that effort not rather be spent getting patients quicker to hospital? And then lastly, is this an intervention just for patients who've had penetrating trauma, or is it also for patients who have blunt trauma? And I think any of us who know the literature, there's a lot about dichotomizing these patients into penetrating or blunt trauma. So what we did was London's Air Ambulance Service from 1999 to 2019, so 21 years, we included every single pre-hospital thoracotomy that we did. And the outcomes we were looking at was, primary outcome was survival to hospital discharge. We also looked at survival at 3 months and 6 months, and actually there was no difference. Anyone who survived to discharge survived beyond 6 months. Secondary outcomes was survival of the event. Now this is, if you resuscitate the patient, you get a good return of spontaneous circulation, the heart's beating, generating a blood pressure, and it's sustained, and you get them into hospital and you hand over care to the hospital, but then they die in hospital. So that's what I mean by survive the event. And then we also looked at neurological survival, and we used a cerebral performance category to scale whether it was favorable or unfavorable. And it's probably important to know what we were doing, what was the intervention we were giving to put this in place. So how we do thoracotomies on London HEMS is via quite a strict standard operating procedure. So first up, before you even start, is the patient must have had bilateral thoracostomies to exclude tension pneumothorax. And then if there's no response to that, then we proceed to doing a clamshell thoracotomy. And then the next step after that is we open the pericardium in an inverted T, and then we can evacuate any tamponade. Following from that, we repair any wounds to the heart. And then step 4 really depends. Sometimes the heart actually starts beating again or is beating. Then you don't need to do step 4. Other times it's not beating, and then we restart the heart with resuscitation of the heart. And this consists of aortic occlusion, good quality internal cardiac massage, and volume. So blood if needed. Sometimes I don't need the volume, sometimes I need a lot of volume. So that's what we do. And these are our overall results. So in the 21 years, we saw just under 46,000 seriously injured patients, and 601 of those patients had a pre-hospital resuscitative thoracotomy. Now, contrary to what some of you might think of London HEMS, that means only just over 1% of patients in our system get a resuscitative thoracotomy. We then looked at why they had had their arrest. So just over 100 in cardiac tamponade, just over 400 from exsanguination, a group who had both tamponade and exsanguination, and actually only 6 patients out of the whole group. It was unclear what had happened, or that had something else like a major airway injury or myocardial contusion. So 99% of patients either had tamponade or exsanguination. So, is it futile? And I'll start off by just talking through the cardiac tamponade groups. I'm going to split them into the cause of arrest, because that's the aim of resuscitation, is treat the cause. So this is probably the most important graph I'll show you today. I'll just talk you through it. So this is the chance of survival over here against how long you've been in cardiac arrest. So this 0.0 is when you go into cardiac arrest, and then when you get your thoracotomy. And overall survival here is 21%, okay? And two important points. Firstly, if you get your thoracotomy at the point of arrest, you've got a nearly 60% chance of survival, and then a rapid decline, and by 15 minutes, we have no survivors beyond 15 minutes. The second important point is this is both blunt and penetrating, and when we separate them, the graphs are exactly the same. There's no difference between blunt and penetrating trauma. That both of them have more than 20% chance of survival if you relieve the tamponade. And both very strongly correlated with the duration of cardiac arrest. This is essentially the same information, but now I've put all the outcomes. So the light gray is the survival to hospital discharge. This medium gray is the survived the event, so the patients who have a good ROSC but then die in the hospital. And the black is those that die on scene. And then I've broken it down into time categories rather than continuous. And what you can see here is that almost all the survivors are happening in the first 10 minutes. And actually, if you look at the first 10 minutes, about 80% of patients are making it alive to hospital, and actually about 40% are surviving to hospital discharge. And I put that into context of an intervention for cardiac arrest that will give you, for out-of-hospital cardiac arrest, that will give you a 20% chance of survival to hospital discharge. And if you do it within the first 10 minutes, will give you a 40% chance of survival. That's a very effective intervention. There's not much else that is that effective for out-of-hospital cardiac arrest. Here, I've just overlaid in the survivors, those with poor neurological outcome in red. And what you see here is that the poor neurological outcome is just correlated with time. So the longer you've been in arrest, as you would expect, the more likely you are to have a poor neurological survival. And then just note here, we didn't have any good neurological survivors beyond 10 minutes. That said, I've learned a lot. Last year you might have met Frank Chege, one of our nurses on London HEMS. He follows up all our patients. And we stand up here and talk about poor neurological survival, and I get Christmas cards and that from our poor neurological survivors saying, thank you so much. I spent Christmas with my family, and they have good quality life still, some of them. So I just make that note that you can still have good survivors. Doing the same for exsanguination now. So this is the graph for exsanguination. Completely different story to cardiac tamponade. So overall survival, just under 2%, and no survivors beyond 5 minutes. So basically all the survivors will witness cardiac arrest from exsanguination. Comparing the two, so here we've got cardiac tamponade, there exsanguination, it's an order of magnitude difference. There's over 20% survival here, less than 2% survival there. So two different causes of arrest, order of magnitude difference in survival. And showing the same, again, cardiac tamponade on the left-hand side, exsanguination on the right for all of the outcomes. So again, light gray is survived to hospital discharge, dark gray is just a good ROSC to hospital, and then black is died on scene. And you can see that all the outcomes are closely correlated with how long you've been in cardiac arrest for. And all of the outcomes, it's an order of magnitude difference in outcome. Essentially here I'll show you on the next slide. If we just look at the exsanguinators, beyond 5 minutes, essentially 90% die on scene and don't make it to hospital. Less than 10% will have a ROSC and get to hospital and then die there. And just a few survivors. Out of over 400 patients, we have 8 survivors in this time frame. So, just going back, so clearly, the technique we're doing, thoracotomy, the way we do it, is not effective for exsanguination. I think that's clearly futile when you're getting a 1% survival in 400 patients. But we did want to try and learn something from these 8 patients and see where we go from here. So I've just listed the 8 patients here and some important attributes. I'll just talk you through them. So one thing we noticed that all of our survivors had a penetrating injury, both gunshot wounds and stabs. The sites of hemorrhage, it didn't matter, because you might think, well, we're doing a thoracotomy, so you'd have survivors from thoracic bleeding and not from anywhere else. But actually, we're getting survivors from the neck, the chest, the abdomen, even down in the thigh and groin. But really important is that every single one of the survivors still had organized cardiac activity. So no one's heart had actually stopped. And they all basically were witnessed arrests. They all had aortic occlusion, and this compared to the people who died, only about 2/3 had aortic occlusion. Some of them didn't even need internal massage, so after doing the procedure, the heart was actually beating fine. And then this is a really important point here. They had big transfusions. So in the early days, we were using crystalloid, and then later we were using blood. WB stands for whole blood. Now, these don't look big in the context of in-hospital resuscitation, but you've got to consider what we're carrying, and basically, they were getting everything the team had, because we started off carrying 4 units of blood products and then moved to 2 units of whole blood. And basically, the teams were giving everything we had and then a little bit more, whatever liquid you could find in the ones who survived. Interestingly, we've now carry a lot more blood on London HEMS. We carry 8 units and can even get a further 4 or 8 units if we need. And all of us here presenting today in the last year have had survivors from exsanguinating cardiac arrest, many with thoracotomy. But the interesting thing in all of them have had more than 10 units of blood pre-hospital to have the survivor. So this, I think, is the real key, is we were just always underdosing them in this data set. And finally, the exsanguinating survivors tend to have a very good neurological outcome. So what's difficult for our teams is when you arrive to these patients, most of the time we're arriving there already in cardiac arrest. Only about 20% of cases we witness a cardiac arrest. So most of them are already in cardiac arrest. So it's understanding what's the survivable window and making a quick decision in whether this patient fits within that window or not. So we wanted to look at whether there was anything else that could help. It's been a continuous problem all along. The information you're given as you arrive on that scene is always very unclear. The timings are very difficult to base judgments on. And it's a constant thing in our review of cases was, retrospectively, when all the information comes clear, you were doing a thoracotomy on someone who had been in arrest for 40 minutes. It's totally unsurvivable. But at the time, you didn't know that. So what can help us? Now, one thing that does happen is the first teams that get there, because medical cardiac arrest is so clear in what you need to do, is they have pads slapped on, they're on a monitor, the defibrillator's out, okay? So they all are actually usually attached to a monitor, but we tend to just ignore that. So I wanted to have a look if the ECG rhythm could be of any help. So what I'm showing you here, again, this is for the tamponade group, and then I'll show you the exsanguination group in a bit. But this is what rhythm they were in when the decision was made to do the thoracotomy. So all patients were either in pulseless electrical activity or in asystole. Those that were in a sinus rhythm, so tachycardia, or they had on average been in cardiac arrest for only a minute. Those that were bradycardiac, they had been in arrest usually for about 3 minutes. And those with a wide complex agonal rhythm for about 7 minutes, and the asystolic patients had been in arrest for about 15, 16 minutes. And this pattern is not, this is what you'd expect. This is a known pathophysiological reaction to a hypoxic heart, that it will slow down, the complexes will widen, and then it will degenerate into asystole. But it was really good to see it in our data so clearly and how closely correlated the rhythm was with the time. Now, I said the outcomes are closely correlated with time, so if the rhythm's closely correlated with time, then the rhythm should be correlated with outcome. So we had a look at that, and it definitely was. So patients in a sinus rhythm had about a 60% chance of surviving to hospital discharge, whereas those in asystole had a less than 10% chance of survival to discharge. And again, just overlaying the unfavorable neurological outcomes, and you can see that the worse the rhythm, which was associated with the longer time, the more poor neurological outcomes you'd get. We did the same for exsanguination, and essentially exactly the same pattern, just the timelines a little bit quicker. So just moving through those gears a little bit faster. So they were in asystole within 10 minutes and agonal rhythm within 5 minutes. And again, closely correlated with outcome. As we said, we only saw survivors in patients who had organized cardiac activity, and there they are. So a little thing to help the decision making, because we want to move away from trying to find out how many minutes someone's got, because that's tough. But if there's any kind of organized cardiac activity, and I've labeled that specifically, it doesn't need to be on the ECG. This can be on ultrasound, but if there's any organized cardiac activity, then you proceed if you think that thoracotomy is the intervention you need to do. If there's no organized cardiac activity, then if you are suspecting tamponade, then the patient needs to have been in arrest for less than 15 minutes. If you are suspecting exsanguination, for example, a stabbed groin or something that can't give you a tamponade, then if there's no organized activity, they are essentially dead. Pre-hospital or in-hospital. So this data here, now this, what I'm showing you here, again for cardiac tamponade first, is how long since the point of injury. So 0 is when you get injured. And then up here in the pink is how long it takes after your injury to go into cardiac arrest. So on average, in patients with cardiac tamponade, half of them would be in arrest by 11 minutes after their injury. Okay. And, but you can see patients are still arresting 50 minutes after their injury. This is our response time. So just on average, it takes us 20 minutes to get to patients, and then you can kind of see the overlap. We missed the majority of patients. You know, they were usually arrested before we get there. And this is the time to thoracotomy, just showing you they usually get their thoracotomy about a minute after we arrive. So very quick decisions. Same data for exsanguination. So the exsanguinating patients, a little bit longer. So from the point of injury, about half of them, so the dark bands are 50%, half of them have gone into cardiac arrest by 14 minutes. But a long tail here, so patients are still arresting an hour after injury. And as you'd expect, our response time is exactly the same, 20 minutes, and they're getting their thoracotomy pretty quickly after that. Finally, penetrating versus blunt. So in our data set, we did a logistic regression analysis, multivariate logistic regression, 600 patients, we could do this. Only 2 things came back positive after adjusting for confounding. So what caused the arrest and how long they've been in arrest for. The ECG was also positive, but it's so confounded with duration, as I showed, that we took it out the model. So those are the only 2 factors that make any difference. So in summary, take-home messages are traumatic cardiac arrest occurs so soon after injury on average that essentially if you want some kind of beneficial intervention, you're going to have to do it pre-hospital. In our system, it takes about 50 to 60 minutes to get into a major trauma center, and you can see from this data that half of patients are in arrest within 15 minutes. How we do the technique, very effective for tamponade. I mean, the technique is designed to get a tamponade out, but limited effectiveness for exsanguination. However, there are some markers that surgery might be useful pre-hospital, for example, to get aortic occlusion, but probably it's more about volume resuscitation. And then just the ECG can be informative both for decision making and for prognostication. Great, thank you all.
Right, good evening. So my name's Robbie, and I'm gonna talk to you about some more pathophysiology. But thanks, Sam, for showing me those photos of myself. I think, I need to really re-examine my life choices and look after myself. So thank you for that insight. And I hope you bunch of hypnotized chickens have enjoyed your afternoon and are ready for some more pathophysiology. So what I'm going to do is try and move on from Zane's talk, trying to think about focusing more on bleeding and exsanguination, but a physiological concept that we, I guess, raised last year to drill a bit more into it, to really understand why we end up with cardiac hypoperfusion. And I hope to convince you this is important because it's almost certainly involved in this cohort of patients we're talking about that die within the first few minutes or within the first 72 hours. And then I want to, having understood that pathophysiology, look for physiologically targeted interventional opportunities to try and address the pathophysiological problem and mitigate myocardial hypoperfusion and hopefully improve outcomes. I'm hopefully not going to fall off this stage as well, but it's a possibility. And then I hope to persuade you that I think it's time to move on from the concept that the only way to manage a bleeding trauma patient is to give them a blood transfusion and drive or fly faster to hospital. Undoubtedly, these are integral components to managing this cohort of patients, specifically minimizing time to definitive care. And we've already seen the Colonel's data in terms of the benefits of early blood transfusion. But really, to get to the next level, to see the next gains, we need to understand this physiology and direct targeted intervention. So I want to bring you back to the 19th century. And Zane talked about this last year, but it's important. I just want to recap. So this is Otto Frank's Windkessel. And just like the fireman's hose, where the air chamber converts pulsatile flow from the pump into constant flow at the tip of the hose, your thoracic aortas are doing the same thing. So when your heart ejects blood against resistance, generating pressure, that causes stretch of your thoracic aorta, which stores potential energy. And then when the aortic valve closes, in diastole you have recoil, you pressure. And this is really important. So there are a number of other theories, including a wave theory, which have challenged each other over the years. But it's generally accepted now that these two theories are, these two mechanisms are responsible for blood pressure generation. But what I want you to focus on is the reservoir component. So this is, the black line is measured aortic pressure. And you can see that the red line, which is the reservoir component, is almost completely responsible for the generation of diastolic blood pressure in a human, okay? And I think this was sort of hit home to me, really looking at a transesophageal echo one day. So I'm a cardiac anesthetist, and this is a transesophageal echo. So this is pulse wave Doppler sample in the thoracic aorta. And what the graph shows here is velocity over time, okay? And if you look at the ECG, you can see that the only antegrade flow of blood, so blood moving forward, happens during systole, okay? So during diastole, there's absolutely no forward movement of blood. So you're not having blood pushed into your tissues. So the perfusion of your tissues during diastole occurs as a result of this mechanism. So there's no forward flow, but there's perfusion because of the thoracic aortic pressure reservoir. There's actually a little bit of retrograde flow due to that recoil. So the relevance of this, well, coronary blood flow, so perfusion of your heart, happens during diastole because the pressure gradient that perfuses your coronaries is the difference between your measured aortic pressure and your aortic root and the pressure in your left ventricle. So left ventricular wall tension, where your coronary arteries are, the difference is the perfusion gradient that causes coronary blood flow. So the issue is, if you lose your ability to generate diastolic blood pressure, you've got a bit of a problem. And it's likely that when you have a hole in your arterial system, so when your heart ejects blood into the thoracic aorta, the resistance it's ejecting against is less, so the amount of pressure generated is less, so the amount of energy stored in your thoracic aorta is less, and that recoil is against a lower resistance because of the hole. So you can potentially disrupt your mechanism for generating diastolic blood pressure, which from the heart's perspective is really important. So we mentioned this last year, and Zane presented some examples of this, and I just want to build on that in terms of have we got any evidence for this mechanism? So just want to take you through these graphs. So these are all shocked patients, pre-hospital patients who've had an arterial line inserted. So on the left, you have patients, these two patients have arterial injuries. These patients have hypovolemic shock but no arterial injury. And if you hypothesize what happened based on what we've said, you might expect to have, with an arterial injury, a lower diastolic blood pressure. And as long as your heart is still ejecting blood and active, and you're maintaining some kind of a systolic pressure, you might see a wide pulse pressure. And these are cherry-picked examples, so this is just to illustrate this point, and this is early evidence, but both of these patients have a low diastolic blood pressure, and in this context, a wide pulse pressure. So normally, my understanding was you bleed, your stroke volume falls, you vasoconstrict to maintain your blood pressure, your pulse pressure narrows. Yet here we've got, and we see this quite commonly, and we're hopefully going to report on this in the next few months, these patients who have abnormally wide pulse pressures in the context of arterial injury. Whereas if you're shocked and you don't have an arterial injury, often your diastolic blood pressure is higher and you don't have that wide pulse pressure. So potentially we have some early evidence that this might be, a physiological problem. But what you really want to know is you want to relate this to coronary blood flow. So this is a graph from a large animal model of hypovolemic shock from Johnny Morrison's group in Minnesota. He's a Scottish chap, but he lives in the US these days. So these are pigs who've been venesected. So they're hypovolemic, so they're bled till they have a blood pressure of 50 systolic, but they don't have an arterial injury. Okay, so at the top you have normal coronary blood flow. So they've actually dissected out the left main coronary artery and put a flow probe onto it. So this is actual measured coronary blood flow. And you can see, there's no ECG unfortunately, but this is diastolic blood flow with this peak in late diastole. What I want you to take from this shock recording, and there are a number of interesting factors to this, but the key thing is, if you're a hypovolemic pig, in systole, you actually get retrograde flow in your coronary arteries, okay? And that's because you've got hyperdynamic heart, high LV wall tension, a low pressure in the aortic root. You actually get retrograde flow in systole, okay? But you've still got some flow in diastole, and interestingly, you've got a swing in your diastolic flow, which relates to the fact that these pigs are positively pressure ventilated, so their blood pressure is varying, and the amount of energy, your potential energy stored in the thoracic aorta is changing, so you have this swing. But the key thing to take from this is you get retrograde flow in systole, but if you then overlay this mechanism or concept of arterial shock in somebody who has an arterial injury, and you abolish or very much diminish diastolic blood flow, you can see there's a bit of a problem, and it's likely that people with arterial deflects and hypovolemia get pretty profound myocardial ischemia very quickly. And part of that, and that's the reason why, as Zane's just showed, once these patients deteriorate exceptionally quickly, but once their hearts have exhausted their resources, they're very hard to restart. So in terms of biochemical evidence of this, so this is a data set which again is going to be published shortly, but it was presented last year, but I just want to highlight its importance. So this is shocked consecutive group of hypovolemic trauma patients, so humans, categorized into patients with arterial injuries, venous bleeding, and a control group. And this is HFAB, so heart-specific fatty acid binding protein. So a marker of myocardial ischemia. And you can see there's a far greater spike in the patients categorized into arterial injuries and hypovolemic shock. So potentially some early evidence of myocardial ischemia with this concept. But we also wanted to look at organ failure in general. So this study, which I'm going to present the data from, was conducted by a chap called Rich Carden, who completed his PhD under Karen Broy at the Royal London. And it's got some fascinating data regarding to organ dysfunction, which again, I think we can potentially relate back to this type of pathophysiological problem. So this is over 1,000 patients, consecutive trauma patients that came to the Royal London Hospital. And of those that were admitted to critical care, 32% of them had cardiovascular dysfunction, and that's categorized as a SOFA score in the cardiovascular domain of 4. So the SOFA score, I'm not going to go into, but essentially in that category, it's based on catecholamine prescription doses. So it's, the definition is slightly, not that helpful, but that's the definition of cardiovascular dysfunction used in this study. But you can see in patients who are injured, cardiac dysfunction is actually pretty common. If you look at the prevalence of cardiovascular dysfunction amongst those who died in ICU, though, prevents cardiovascular dysfunction in those who die. You can see that in the injured patients who died in ICU, 80% of them have cardiovascular dysfunction. So it's not hepatic dysfunction. This is far more common than I ever thought. This is a really important finding from Rich's work. If you look at the temporal aspect of this, these patients that had cardiovascular dysfunction, you can see that around 70% of them who died in critical care have cardiovascular dysfunction on the first day after injury, so day 1, and that quickly tails off. So it very much fits with that. The description we've heard from a number of speakers in the conference that, this death over 72 hours, either early or patients are dying quickly as a result of hypoperfusion that they've suffered in the immediate post-injury phase. And really, I think this group is stratified probably into 3, although it's a continuum. So Zane's already presented this. The group who have a pre-hospital cardiac arrest, profound myocardial hypoperfusion early on from exsanguination, die very, very quickly. There's then this type of patient, which is something we see really reasonably commonly in London. So this is a young guy who's had a blunt mechanism of injury. He's got a hepatic arterial injury. And this is him, 43 minutes post-injury. He's got an arterial line in. He's having a blood transfusion. And he's got a blood pressure of 63 over 16. And he's got myocardial ischemia on his ECG. So this chap survived to 40 minutes, but he's imminently going to die, probably as a result of this hypoperfusion to his heart. And then finally, the group that we saw on the last slide, who are likely to survive for 72 hours. So this problem is impacting patients in slightly different ways, but they're ultimately all developing cardiovascular dysfunction and dying as a result. So what can we do about it? So I think, as Zane's talked about with the thoracotomy data, tried to address the underlying pathophysiological problem, and we have now experience with using REBOA as a way to do this. And we've just completed an observational study of Zone 1 partial REBOA, and this is some data from that, just to try and show you the kind of potential utility of targeting these pathophysiological problems. So this is a case example of a patient in the PPRO study. He has an arterial line inserted. He has a wide pulse pressure. He's deteriorating despite a blood transfusion with a blood pressure of around 50 systolic, a diastolic less than 25. And when this patient has Zone 1 REBOA, so he has an aortic occlusion balloon inserted in his thoracic aorta. And the key things I want to take from this is he has an immediate jump in his diastolic blood pressure. And that's almost certainly as a result of the intervention removing the defect from his vascular tree, allowing his pressure reservoir to function, and allowing him to generate diastolic blood pressure again. And then you can see he has this gradual recovery in his blood pressure, which I think is a combination of cardiac recovery as well as preload restoration in the context of some hemorrhage control from the intervention. But I think we have an opportunity to try and target this pathophysiological problem with this type of intervention. But what we really want to know is, what does it do to coronary blood flow? I'm going to take you back to Johnny's work. This is the control group, the baseline at the top. The shock model we've already talked about in line 2. So in the third line, this is the coronary blood flow measured with Zone 1 REBOA. And you can see that there's an immediate restoration of coronary blood flow, but the issue is it's actually hyperemic flow. I mean, it's supernormal coronary blood flow with Zone 1 REBOA, which is not ideal. And then with partial REBOA, you can mitigate that peaking coronary blood flow to a degree, but it's still supernormal. So potentially we can restore coronary perfusion, but that's not ideal. But I want to reflect on that in the context of our recent experience, because one of the problems with this pig model is if you look at the individual pigs, most of them had a supernormal increase in their blood pressure. So they were really hypertensive with the intervention, which correlates with this hyperemic flow, which is not what we've observed in a clinical context. So the PEPO study is an observational study of zone 1 partial robot. It includes 15 patients. So it's a small cohort study. These are a severely injured group of patients. 50% of them are in traumatic cardiac arrest. But what we found is that due to this myocardial hypoperfusion that's occurred, none of the patients became hypertensive post-intervention. So I think potentially in the group of patients we're targeting, who are profoundly sicker than the pigs in this kind of model, this will be mitigated to a degree, but we don't really know. The other thing that I think is important to share from the PEPO study, I'm not going to tell the entire study, but I think some of the learning is key to this kind of targeted physiological management. Our aim was to introduce partial rebirth, so allow some flow past the balloon to mitigate the distal ischemia that's created. And we were able to do that. So we've shown in this study, which will be published hopefully in the next few months, that zone 1 partial rebirth is feasible. So we augment proximal hemodynamics while creating an area of distal regional permissive hypotension around the site of injury. But the interesting thing about the partial Reboa in this study is in the patients the 10 zone 1 Reboa patients in this 15-patient cohort, 70% of these patients developed partial Reboa, partial flow spontaneously. So what's essentially happening is, because the aorta is just occluded, as the proximal pressure increases, preload increases, stroke volume and blood pressure increase, we saw spontaneous flow past the balloon. So that does two things, both mitigating distal ischemia, but the other thing is it sort of self-regulates the afterload. So as long as that happens, as the pressure increases, you have more flow, you're unlikely to experience proximal hypertension and that coronary hyperemia that we saw in the animal model. And this is an example of that, just to finish off this description. So taking you through this is pressure above the balloon, pressure below. There's already partial flow past the balloon. But in this next image, you can see the proximal pressure above the aortic balloon is the same effectively, but the distal pressure has increased substantially, but no volume has been removed from the aortic balloon. So this is purely as a result of proximal resuscitation, essentially, cardiac recovery, and more spontaneous flow. So just to bring all this together, I wanted to describe a case to try and illustrate how we can target this type of physiology and potentially, ultimately in the future, improve outcomes. So this is a chap he's fallen 110 feet, so 35 meters, out of a building into a basement. And he's lying in this basement, which is open to he's fallen down into an open basement. And he has severe open limb, pelvic fractures, abdominal injuries. And the team arrive and start a high volume blood transfusion through a 9 French trauma line and put in an arterial line prior to getting him extricated from this basement. So I want to take you through this graph. So this, we seem to have lost his diastolic blood pressure here, but this is his mean arterial pressure and this systolic blood pressure, okay, from a femoral arterial line. He's having a blood transfusion. You can see he's volume responsive, but he's still hypotensive, and this is giving as much blood as we can as quickly as we can. During extrication from the basement, he comes out, and a decision is made that he's deteriorating, and the team are going to do zone 1 Reboa. The sheath size is changed, and here you can see his blood pressure pre-Reboa. So his mean pressure is about 45 systolic. The balloon goes up, and immediately he has recovery. So this is his systolic pressure, mean arterial pressure, and diastolic blood pressure above the balloon. And this is the distal pressure. So this drops with the occlusive balloon, and his proximal hemodynamics increase. You can see the immediate jump in his diastolic blood pressure. Accidentally, someone deflates the balloon at this point. You can see his distal pressure jumps, and his proximal pressure decreases. But that is rescued, and his hemodynamics improve. But here, you can see the distal mean arterial pressure, which increases. So he develops spontaneous partial Reboa on his own. He gets to hospital. Further volume is taken out of the balloon now, so you can see the increase in distal pressure, which he tolerates. and actually the balloon's deflated in the ED, okay? So his hemodynamics have been sort of rescued or, at least controlled, and he gets to the ED like that. So the balloon then comes down in ED, okay? He's connected to a Belmont now, high volume transfusion. So this is now just the mean arterial pressure on the sheath and the tip of the catheter. And we enter this period of cyclical resuscitation. So his blood pressure drops, he gets volume. It drops again, he gets more volume. And these swings increase and the depth increases. And then ultimately, as he's in the operating theatre or en route to theatre post-CT, the balloon is reinflated to get some more control. So really now, in zone 3, so the distal aorta, so this is now about hemorrhage control rather than cardiac resuscitation per se. But, he has nice stable hemodynamics then progressing into the perioperative phase. So I wanted to show you that just to try and, I think this is the future. If we can target these pathophysiological problems to mitigate transfusion volume, mitigate cardiac hypoperfusion, we can potentially improve outcome. So finally, the future. This is, this is all great and nice, and we're excited about it, but it's easy to look retrospectively and identify patients who have had cardiac dysfunction and died. The challenge is prospectively identifying them. It's pretty hard to pick these patients, especially if you've got somebody who, he's having a transfusion, might survive to hospital, but yet you don't know if he's a patient who's going to get cardiac dysfunction and die on day 2. That's the challenge. And really starting to understand these pathophysiological signatures, link it to evidence of organ dysfunction, and then outcome, and then using machine learning to help our decision-making is really the future. We have this type of technology in our operating theatre. This technology from Edwards predicts hypotension using pulse contour analysis and artificial intelligence. So I think, I hope that in the not-too-distant future, we can start to inform our decision-making better, and then perhaps to make this more generalizable. So, the patients who die in the first few minutes to the first 72 hours, I think, and I hope I've, given you some insight into the fact that it's likely they die as a result of coronary hypoperfusion and the impacts that has on their heart, that hopefully we can target these aspects and therefore look in the future to improve outcomes with this type of care and, move on from the current paradigms of trauma resuscitation to really produce the next generation of survivors. Thank you very much.
How's everyone doing? Is everyone okay? Sorry, Ross, there's a lot of graphs and a lot of stuff that we're not supposed to do. But please just try and hang on to some of those, Listen, put your knife away, chill out, right? Try and hang on to some of the stuff that you've heard. We're going to keep repeating it as we go, right? We're halfway through this session, more than halfway. Fondue is coming closer. But we're now going to hand over to 2 of our paramedic colleagues, and I think one of the reasons, probably the most important reason that we doctors don't get sent out alone is because we can get lost in the science, and these guys bring us back down to earth and help us turn the science that can be quite heavy on the brain back into practicality. What do you do with this person who's right there in front of you? While I'm pickling over arterial pressures and cardiac physiology, they're like, dude, we need to go to hospital. Give him some blood. So I'm going to give you these 2 who are going to bring us back to earth and with the how we turn that science into practicality. Over to you, Joe.
Thank you, everyone. My name's Joe. I'm one of the HEMS paramedics with the Advanced Trauma team. And I want to spend the next sort of 15 or so minutes chatting about what actually happens before we, as an advanced trauma team, get to the patient and how we dispatch the team and the kind of nuances of what we do to get to the patient in the quickest time possible to intervene. In that note, half of the HEMS role within London is to dispatch the team. So we have a clinical dispatch model where half of my job is to dispatch the team and the other half of my job is to be on the team. I thought I would have a quick look at what a typical day of London actually looks like, just to frame it for you, because we're a fairly unique geography. So we are obviously an urban built-up area, 620 square miles, a fluctuating population between 10 and 12 million, depending on what time of day it is. We have 4 MTCs, and we're quite a big city, lots of buildings, lots of complicated geography in that. Now, a typical day in London, obviously, lots of people call 999. About 6,000 actually call 999 within the M25 every single day. And that's about, since I literally stood on this stage, the ambulance service would have probably taken 3 to 5 999 calls for someone requiring help in London. We have lots of ambulances, so we're paramedic-led EMS in the UK, probably about 400 assets in London, depending on the time of day. And we only have 1 advanced trauma team, so 1 in the night and 1 in the day. And so the target and the difficulty is how do we find those patients? And how do we find the patients within the huge amount of volume that's coming through? Now, on a day-to-day basis, about 20 patients go to a major trauma centre in London, of which about 4 to 5 of them have an ISS of greater than 15, and that's the patients that we want to be at. And that's about 0.1% of all those 999 calls. So it's tricky to figure out how to actually get to them. This is a very brief breakdown of what we did last year. So we saw circa 2,000 patients last year in the advanced trauma team. I'm going to talk about stabbings in a little minute. Keep the 25-minute time frame in your head. That's the median time it took us last year from point of 999 calls, so when the ambulance service answered the phone, to us literally being right next to the patient. Sometimes a bit quicker, but the median time was 25 minutes. So frame that in the graphs that the team have just described and the time frames that we've chatted about there. Now, obviously, there's lots of stabbings in London, sadly. So the MPS, so the Metropolitan Police data last year, said there's a circa 8 to 10 stabbings in London every single day, and we go to 2 of them on average, which is 34%, roughly. There's a few gunshot wounds in there, but predominantly we go to stabbings, so 34% of our caseload. The second are traffic and fall from heights, but I'm going to focus on the kind of stabbing from this point of view. So, what do we actually do with a 999 call when Samy decides to get stabbed in the chest in central London? What actually happens? So obviously, you'd hope someone would call for help. And yes, you call 999, and in our system, you get put through to a BT operator who asks you, what service do you require? You then say ambulance, and you go through to an ambulance call taker. Now, I don't know what happens in the rest of the world, but in our system, it's a non-clinical person who answers the phone and follows an MPDS algorithm. MPDS is a fairly kind of universal system that tries to identify what's happened and tries to do a very scripted approach to the care that the patients that we see. The script is all well and good, and there's a time frame involved in getting to what you think the right script is to actually talk to. And then it's a very scripted approach that they're not allowed to go off-piste with to actually nuance the care. So the difficulty is that, yes, these 6,000 calls come into London every single day. Yes, they go through a non-clinical dispatcher MPDS model, but when can a person that actually needs some high-level advanced trauma care become involved in this 999 call? And that's where I spend half of my career. So sat at that desk, there's the actual desk, 12 hours of a shift to sift through all of the calls and figure out what we can actually do for these patients and which team or which patient actually needs the team that's on duty that day. And actually, more to the point, which patients don't need the team, because it's actually quite a shouldering risk to figure out what team actually, the patients don't actually need the team, so they can be available in the timeframes that my colleagues have described. So, lots of 999 calls come in. How do we actually do it? So we have a few types of dispatch. Depending on where you work, and depending on where you work in the UK, actually, there are some non-clinical dispatchers for HEMS and some clinical dispatchers for HEMS. We're a clinical dispatch. We have a few immediate criteria, which is effectively, if that happens, we send the team without much thinking, and that's from the kind of this sort of history of those kind of presentations. The mechanisms of injuries are likely to be quite a high velocity and quite a lot of sick patients. However, that was only 10% of our dispatches last year. The vast majority, 70% of them, was what we call an interrogate style. And so the HEMS paramedic in the control room had to make a decision, a clinical decision, to actually send the team. So how do we do that? So primarily, I listen to a lot of 999 calls. We can be involved from the first 5 seconds of a 999 call and actively listening in the background, silently listening in the background to actually try and understand what's going on. And effectively, we're trying to make a physiological assessment of a patient without being there, without seeing them, and just listening to what's going on. So frame it for yourselves. If you were sat there and just listening in the background, what would you actually think to listen for to decide, yes, an advanced trauma team is needed? For me, I think it's a lot to do with stress levels and sometimes not actually the patient, sometimes what's going on around the patient. But with the patient, things that Samy was discussing and saying earlier, how are they interacting? One of the MPDS questions is the patient alert? Well, what actually is alert? So alert for me might be completely different to alert for someone that's never had any kind of medical training. And so you kind of get the nuances of, what's this patient actually sounding like? Are they making sense? Are they moving all of their limbs? Are they kind of being a bit weird or a bit kind of, sort of agitated, but are they stressed? I would say, for me personally, I use a lot of what I hear to make a decision about whether we send to a job. Good SAM, which I'm sure you're aware of for the cardiac arrest kind of response program, we have the ability to use Good SAM and send a link to people's phone and actually see the scene. So you can actually activate their camera and see the scene. Then I can see the patient, see what colour they are, how are they actually interacting, and it informs my decision making about what to send whether to send the advanced trauma team to. On average last year, it took our teams in the control room 6 to 6.5 minutes to make a decision to send the advanced trauma team. So there's a window of opportunity from 999 call, 6.5 minutes, think about the bleeding patient, and then from then another 16 to 18 minutes to get the team to the patient. So that's what the 20 to 24 minutes is. So you're listening in, it's 2:15 in the afternoon, a 999 call comes in. It's a patient actually Robbie and I went to, we were on the team that day. Argument, man and wife. Got a bit stroppy, been drinking, had an argument. Wife stabs husband in chest. Yeah, awkward. My colleague was listening in the control room. The patient was just screaming, generally hacked off, just had an argument with his missus. Was refusing the ambulance, says, put the phone down, don't want the ambulance, don't care, leave me alone. The paramedic in the control room was listening in and sort of thought, are you just hacked off, or is there actually a bit of a problem here? MPDS, which is a non-clinical, was being hindered because of this kind of stress and this and this sort of aggro that's going on. And so my colleague in the control room took the call over that day, so we were allowed to silently interrogate and then also take the call over and ask some very direct questions, completely what we like, based on the physiology that we think is going on and what we can actually do for the patient. And it was just a bit aggy, something wasn't quite right. My colleague felt that he was just a bit weird. He was kind of screaming a bit. He kind of went a bit chilled out. Then he sat on the sofa and stopped talking, and then refused to talk to you. And the paramedic in the control room asked the other person that was on scene what's going on. He just says, well, he just sat down. He's panting. He's breathing really fast. Something's a bit weird. He starts to kind of flop back and his eyes kind of roll. And this all happened in the first kind of 3.5 minutes of the 999 call. And so my colleague activated us and we arrived at the patient's side 20 minutes later to find a patient in extremis inside a house with EMS on scene, putting blood pressure cuffs on and trying to get IV access. We did a bit of a patient assessment, dragged the patient out of the house and did an assessment out on the street. And because he was kind of just about sort of keeping verbal contact, moving to sort of pain, we elected to do a ultrasound. At which point we're like, oh dear. So clearly that's a cardiac tamponade with a single-sided left chest wound. to a patient that was kind of falling off a cliff in front of us. In the 13 minutes that we were there, we saw a decline, so an absolute decline off the kind of baseline that my colleague literally was speaking to him on the phone. He was refusing an ambulance. To 20 minutes later, we were seeing a patient that was pretty much in peri-arrest state, and so we elected to do a thoracotomy. And much to Robbie's sort of nervousness, the stitch that he had in his RV wound is still in him today, and he's walking around. So he actually self-discharged 3 days later. But that's a completely different topic. So I think this kind of drives home the timings of the fact that we're involved super early in a 999 call, within the first few seconds, which actually, if you go to a non-clinical or just follow MPDS, you get a data package with no kind of informed decision-making, whereas we can actually intervene super early. We can either direct clinical care, not necessarily stabbings, but we can direct jaw thrusts or stuff that allow the general public permission to drag people out of cars and do some essential medicine, effectively, way before the EMS arrive. So I think it's a real privilege and a real focus of what we can do. Now, there's not a lot of research for what we do, whether it's clinician-based dispatch for HEMS or non-clinician-based dispatch. It's actually really hard because it's actually quite difficult to quantify the nuances of what we actually do and the decisions that we make. KSS, which is another air ambulance in the UK, have a non-clinical dispatch model, and they follow a kind of enhanced algorithm with some careful governance. But I see our role very much as an extension of the HEMS team to direct care, actually do some care that's off the MPDS model, and support the ambulance crews before we get there. So some of our challenges that we face, so the hidden time frame, so 25 minutes, there's lots of hidden times that we have the window of opportunity to actually intervene with. Something I didn't mention, but all stabbings in London, the ambulance services are held round the corner until the police declare the area safe to go into. Sometimes we are. By the time we actually get there, often not by air, but often we are at night held. And so there's a sort of 5 to 8 minute window where the EMS are literally 300 metres down the road, being held to let the police go in and kind of declare a scene safe. And there was some safety kind of, scene safe stuff earlier. And in my head, actually, if I'm in the room on a camera, looking at what's going on and having a real insight, I think there's an element, and there's some work going on in London about the risk appetite for actually getting us to these patients earlier. Although not in this case, the vast majority of assailants are not there on scene, when you go to a sick stabbing patient. Very briefly, if another ambulance service answers our call, if we're super busy, we then get a data package of that call, and so we've had no kind of opportunity to silently interrogate or have any kind of idea of the condition of the patient. I think the key to the timeframes and our job is that we can listen in from the first 5 seconds or so and make some really nuanced and some decent kind of clinical decision making. So the future, I think what Zane was saying about the ECG monitoring, there's only 5 patients, super sick from trauma in London every day, and a normal EMS ambulance don't see these patients. We do and I do, and I think we have a real opportunity to intervene and go all in with this sick patient, to actually be on the phone with the crew, support the crew to actually make some interventions that possibly they wouldn't even consider, such as a dying patient, drag them into a space that we can then, real basic stuff that actually do something really essentially well for first time. We can then come and do the interventions that we need to do and not have to kind of backtrack and do the stuff that actually I can coach over the phone. And yes, we have pads on a lot, but how many times do we go to a cardiac arrest and go, pads are on, they're in PEA, they're now asystolic. Actually, what does a PEA look like? And so we don't at the minute, but from the work that we've been doing here, how can we get a snapshot of that heart? And actually, it can be really simple. Pads on, press print, 20 seconds of a rhythm strip. It's time-stamped. We've got an accurate time-stamp of what that rhythm's doing there, and then give it to the team when they arrive. I think that's like a super, super basic thing that no one would think about in the normal EMS world, but we can coach over the phone to then give a decision-making there. So I hope, although a very specific kind of pathophysiology, and in London we're a kind of unique breed, I've given a kind of snapshot of what the clinical decision-making in the control room is all about, and how that we are very much an extension of the team here, and the things that we can do in the first sort of, 25 minutes before we get there to actually augment the care of the actual clinical team when they do get there. I'd happily chat about it in the bar afterwards, but I would be really keen to understand other sort of advancements that we could make in that kind of 20-minute window to then be hand over to the clinical team when they get there. Thank you.
Hi, everyone. Great to be here. And, John, I am Welsh, by the way. I am, sorry, so just put that one. But no, yeah, I'm Mike. I'm a critical care practitioner with Welsh Air Ambulance. But before that, I was really lucky to spend part of my career down at London HEMS like Joe. But the thing is that good things come to an end, and my secondment comes to an end, and then I kind of move from there, and now really fortunate to kind of now fly with the Welsh Air Ambulance, also known as EMERTS. And I feel like I wanted to kind of reflect today of like what Zane and the team and Robbie and Samy are talking about regarding the bleeding patient and how that works now in Wales, and what I've learned, lessons learned, spending a year and a half of my career in London and now what I'm doing in Wales. But to showcase that, I need to kind of show you what we do in Wales and what we do as critical care practitioners, and that's going forward as a profession as well. But first, instead of another kind of helicopter picture, I'm going to put this first picture up, which is a town in Wales. And if anyone knows how to pronounce this, I know there's a couple of my colleagues in the audience, please feel free, but it's the longest word in Europe, 58 letters. Please give it a go. But if they're not, there's a shortened version, Clanfair PG, I'd call it. But essentially, that's the easiest way to dispatch a team to the area. But no, that is Wales. And what I'm going to go forward now really is, we are, a big service. In fact, really, we are kind of the largest air operations HEMS service in the UK. But we have some unique challenges, really, because we've only got one major trauma centre in Wales. Compared to in London, we've got 4. In Wales, for 3 million people, we've only got 1. And geography-wise, it makes it really quite interesting and quite unique challenges, because if you need a major trauma centre in the North Wales, for example, you have to fly to another country, over to England, to send that patient. So just interesting challenges compared to what we got and how luxury we've got in London. But hey, no, 3 million people, yeah, there's quite a small hill on Zermatt in Switzerland terms, 3,500 feet. But yeah, over 700 miles of coastline. And to fly north to south takes roughly about an hour, which is interesting really, because we've only got one team for the whole of Wales at night time. So if you are needed for a critical care asset at night, we are flying, 60, 70, 80 nautical miles up to North Wales. Okay, so it makes it more interesting, really, when you think back about these patients that the team are describing, how does that fit with us now as critical care practitioners and our doctors in Wales? But yeah, daytime-wise, we've got 4 teams, pan Wales. We've got 1 team in the south, that's double paramedic, double CCP, critical care practitioner. 2 more teams at the north, so you've got Welshpool and Carnarvon. One of those teams is doctor and CCP-led, and the other team is double CCP. And a further one down in the south, which is doctor CCP. So essentially, for the whole of the daytime in Wales, we've got 2 doctors, and then the rest are double CCP teams. And it shows there with that kind of the heat map graphic, really, that essentially we've got 2 million people in Wales which live in South Wales, and that's where all our kind of jobs are. And essentially it shows really where we need our assets and where we kind of get our teams to. But essentially we, in a 24-hour period, we can do about 12 jobs in that time. But historically, we started in 2001, St. David's Day, but that was a double CCP team or double paramedic team initially, and that was pretty much stayed for the first kind of 10 to 15 years. We started only as a 5-day operation, but then ended only over to 2015 when we got consultants and critical care practitioners join us. And then since then really our kind of evolution of Welsh Air Ambulance and HEMS in Wales, we kind of really started to evolve our practice and definitely kind of challenge and kind of the UK really now have kind of having the best kind of teams essentially leading forward. But we need to kind of learn from each other. But we are nationally government funded service. We are charity funded as well. And we do have other assets as well as cars and aircraft to get to the team. But we have a mixture of a blend of doctors, registrar, FEM trainees, as well as CCPs delivering this care. And it's there just to kind of provide the equity of care for the whole of Wales. But flipping back to kind of what Joe was talking about, what we do as a team, pretty much 60% of our time we fly to jobs, or to fly to missions, and the rest is car. But then, as you can see there, 44% of our maps really that's where our jobs are in London, in Wales. But primarily, so again, about 60% is trauma, and the rest is 40%, which is medical. So it's a very different, type of patient. For example, I've been now with Wales, and I've been to one penetrating trauma in the last 12 months, which is totally different from my experience when I was up there within London. So how does that bleeding patient look like, or what can we learn from my experiences going forward with the Welsh Air Ambulance? So this paper, this is a service analysis of Lyons et al. In 2021 about EMERTs. And it shows that for blunt trauma, they use data linkage systems. They use pre-hospital data as well as in-hospital data. And they show that essentially, if an EMERTs team, so a physician, a doctor, and a CCP went to a call compared to a normal kind of response by the ambulance service, 30-day mortality was 37% less if the EMERTs team, or the Welsh Air Ambulance, went to the patient. And also a further service analysis that if 41% of less inter-hospital transfers with the EMERTs expansion, and over 60% of our jobs that we go to, we provide a HEMS intervention. So how I want to link back to what Zane was talking about, controversially, maybe a couple of years ago, Blunt doing a thoracotomy, a resuscitative thoracotomy for blunt trauma. This was a patient in Wales. I'll run you through it. So essentially, you are in mid Wales. Your nearest MTC is over 90 minutes away. Okay, you are with a 55-year-old male who has fallen 2.5 meters, had immediate bystander CPR, and when the team got there, a critical care paramedic as well as a doctor, they found this patient in extremis, agitated, combative, but not in arrest. He had a central pulse. Because of the agitation, quite rightly, they proceeded to do a pre-hospital anaesthetic. However, after the anaesthetic, he massively dropped his blood pressure, and they ended up doing a pre-hospital thoracotomy after confirmation of tamponade on ECG. So talking with Zane earlier with blunt thoracotomies, essentially, if you've got a confirmed patient in extremis with a confirmed ultrasound on tamponade ultrasounds, that's what we did going forward. So interesting case, but that's a case that happened a couple of years ago in Wales. So echoing what Joe was saying, really now with paramedics and what we do in the control room, what do we do? Well, essentially, clinician-led dispatch. We kind of mirror what we do in London, the same down in Wales, but we do have a dispatcher that helps me out, just kind of with comms, as you can imagine. We have a number of aircrafts, movements throughout the shift, so I need kind of extra help there. But I don't want to kind of repeat what Joe was saying, but active listening, active interrogation definitely sends teams out, I think, a lot quicker. But as CCPs, where are we going forward? I had a great time in London HEMS. It took me a hell of a lot, taught me a hell of a lot. But now I continue, and I'm very privileged to can continue on my professional journey as a critical care practitioner. But what we look like, our CCPs in Wales, they're either a paramedic or a nurse by backgrounds. They either do clinical shifts as a double CCP or with a doctor, and we have an in-house established training program. However, we've got no national standard for advanced care practice currently in the UK. But what we do is a 5-year program. I've been through the last year of it now. I've gone through my technical crew member course, so I learn flying front lefts. I go on my kind of normal standard ALS, NLS, PALS courses, ultrasounds. I go through my diploma in emergency medical care, as well as a number of placements in ITU, and a number of kind of get my intubations and my experience as well. From there, I do an MSc program. I go on a PG cert with blood transfusion, and that kind of leaves ongoing then for independent prescribing. That's the whole kind of 5-year program that I'm kind of following at the moment. But I've got my CCP portfolio, which is kind of like a constant in the background, constantly working. That's us training, doing our thing, but essentially we just don't do just trauma, as kind of showed in the slides earlier, that we also do medical and neonatal transfers as well, neonatal CPAP. But hey, don't look at that. If I'm totally honest with you, to quote Ross Fisher, and we're more than just skills, and essentially we don't want to be hypnotized chicken, hey. But yes, we can be. We do a lot of interventions out of the scope of a normal paramedic in the UK, but we're more than that. You know, as Samy was saying earlier, we need to kind of keep our doctors in line, but it's all about, you know, teaching the basics well as well. And we're more than that. We're, you know, critical thinking, our knowledge, our experience. Some of the CCPs in Wales have got over 10 years worth of experience. And that's kind of driving change and driving kind of new CCPs coming through as well. And I kind of get an absolute kick out of things when I go to scene, I'm doing a fast scan on somebody, and then the paramedic on scene is explaining to the patient what I'm doing. That's good mentorship. That's knowing what they're doing. They're calling us for an RSI because, you know, they know the indications. They know to get 2 points of access. They know to kind of, you know, get close off, get that fluids primed, ready to go, ready for that anesthesia. Because that's why I really enjoy being a really good mentor. But we go over 170 core competencies, work-based assessments, simulations, case-based discussions. We have a clinical supervisor, consultant-led, as well as another paramedic or a nurse who's my educational supervisor. And from all that as well, I kind of go forward and put all this forwards, and then I put this all into an e-portfolio, and that's what we're, you know, starting now down in Wales. So, you know, from that, then I can continue with my mission logbook. I do my logbook for my airway logbook as well, just to kind of maintain competencies and making sure I can do the procedures that, you know, I've trained to do. To walk through another case study then, so both doctors in Wales that day were unavailable, so they sent, it was a job, he was a 70-year-old who had come off a motorbike at high speed in mid-rural Wales. He was in thoracic cardiac arrest, bystander CPR, and we as a CCP-led team, we provide hot principles, we decompress the chest, intubated, bound the pelvis, and we were querying head, chest, abdominal, and pelvic injuries. The first CCP team on scene, they got Ross pre-bloods, and we were sent further to you know, the ongoing care. And just to kind of echo what Robbie was saying earlier, really, you know, do you just carry on loading these patients with bloods? This was, you know, this patient was a responder. You know, we were we were thinking about retroperitoneal bleeding. On ultrasound, he was underfilled. We ended up giving him 10 units of blood as a critical care practitioner team. And from that, we retained, Ross was maintained. We had a 20-minute flight down to the major trauma centre in South Wales, and we had ongoing care with, you know, comox both from fractures, you know, rocuronium post the tube was placed, calcium, and ongoing ventilator settings. Sadly, this patient died later in theatre, but it was just to kind of showcase for you today, really, of what we're doing here as CCPs. But going forward, and I'm short with time, but what does it look like with CCPs in the future? Ongoing e-portfolio, we've got a number of FEM doctors as well. We've got clinical fellowships with nurses and paramedics, who's going to be the new kind of doctors and CCPs for the future. The pipeline, as I kind of briefly said earlier, that we've got 34,000 registered paramedics in the UK, and we don't know who has got, who is a CCP, how many are a CCP, or what even is that title? Advanced paramedic, critical care practitioner, advanced paramedic or flight paramedic. We still don't know. So we think we need to have certain scope and certain set standards with a broad brush around the UK. And then ongoing future thinking really is whether we as a profession, as paramedics, whether we could do double CCP led RSI. Could be to start off with top cover vetted cases, or even level 3 transfers to carry out, to start off with. But there to finish off with as well, maybe definitely the fellowship in immediate medical care, which can be a good challenge for us as clinicians and paramedics in the future. So, yeah, John, Dolchan Iawn, thank you very much, and thank you for listening. And over to Samy.
Right, I'm going to set my timer because I'm way more nervous about timing than I am about doing a thoracotomy, weirdly. And I want to make sure I don't delay you enjoying cheese and wine. I'll put my little clock there. Thank you, Mike. Thank you, everybody, for all of the different angles, I guess, at the same problem. And I think what I just heard was a lot of data that I wasn't aware of until this year when Zane and his team have dug through it. A lot of science and pathophysiology from Robbie, who thinks hard about this stuff and is lovely and doesn't stab people to death and does brilliant presentations. But it's got me thinking in a very different way when I'm faced with this patient that I can't understand what to do with. And I've heard from Joe how hard it is to find the needle in the haystack. Now, I don't know about all of your systems really, but I think there's different versions of that difficulty all over the world. How on earth you find these people, and then coming back to Zane's data, how on earth you find them quick enough to get the team there quick enough to deal with the fact that we all have to face up to, which is that the ones we really want to be with die early, really early. And how you gear yourself up to understand cardiac pathophysiology over the phone. I mean, it's astounding. And I hear from Mike all of the stuff that he's learned and taken from London and given to London, by the way, and then taken to those distances may not seem long to some of you guys, depending on where you live, but they're massive compared to London. And so, the transfer times are much longer. The environment is very different. The team setup is often different. And I think what I hear there with that case that we ended on is a lot of amazing medicine, loads of amazing medicine. Clinicians that are highly, highly trained, whether they're doctors or paramedics, they're able to give blood transfusions, they're able to give sedation, they're able to give anesthesia, they're able to even do thoracotomies. But still, that patient died, didn't he? And that, why are we telling that story? Because that story is really important, because we've all got that story, I imagine. We've all got multiple versions of that story for various reasons, and it's really, really frustrating. And am I right in saying, Mike, that ultimately that chap had a lot of blood in his abdomen? He had mixed pathology, didn't he? He had spinal injury as well, chest. Yeah, C-spine injury as well. Blunt trauma is not quite as simple sometimes as penetrating trauma, but he did have a lot of blood in his belly. He was bleeding dramatically, and I think he did end up with a thoracotomy at some point. In hospital, was it? Yeah, in hospital. So, relatively late compared to the data we saw from Zane. And he died. So I've got, 15 or so minutes to come back to the questions that we asked at the start. This is the last bit, right? It's a bit of a marathon, this session, but we're nearly there. And my job, I said to you at the start, I'm not a scientist. I don't consider myself a scientist, but like we said, I'm plonked in front of lots of trauma and have been for over 10 years, and I do ask a lot of questions of myself and of why these patients die and what we can do about it. And my job, I guess, in this system, in the machine that is London HEMS, is to translate a lot of the stuff that these guys have taught us into practical ways of dealing with things. And in training, I spend a lot of my time, rather than digging through the data and the literature and pathophysiology, I try and understand that from my colleagues here, and I try and translate that into teaching the team to recognize certain clinical pictures, to recognize when you need to act versus when you don't need to do anything dramatic, and how to do the intervention, whatever intervention it is we decide to do, how to do it as quickly and effectively as possible. That's my part in all this. So if we come back to this idiot who injured the skier and then got stabbed in the abdomen and seems to get himself in all sorts of trouble, and we remember how sick he was. I know I gave you like a sort of evolving clinical picture, but that was evolving over a very short period of time, 10, 15, 20 minutes, right? Remember, he went from angry to agitated to drowsy to I'm going to die, vomit, emptied his bowels top and bottom and rolled his eyes back, right? Along that brief path, having heard everything you've heard, and I know there's a lot there, and there was a lot of science and a lot of data, but we have to understand that data. Otherwise, we're never going to move on from the number of patients that we still can't save. And I think if you all look into your systems, one thing we didn't say at the start is, I think actually Stacey alluded to it, is that there are a lot of studies and a lot of presentations and a lot of papers published which amazingly exclude pre-hospital deaths or exclude early deaths and almost deem them, I guess, unsurvivable or untreatable or I don't know what, but we have to face facts, right? People die early and we need to do something about it. Have we changed what you think about any of these questions? And I'm going to go through them all individually. And it's fine if we haven't. If we haven't, just say, no, we haven't. I feel exactly the same. Someone's got their hand up already. That's brilliant. Hold on. But if we go through them one by one, right? Just tell me what you think. Please tell me if you feel exactly the same. Please tell me if you feel differently about any of these questions. And let's discuss and challenge us as much as you like. If I can't answer the question, I'll palm it off on one of these lot and then blame them if it's wrong. So, go on. Someone had their hand up already. Perfect. So just to repeat that, but I didn't mention, by the way, the people holding the microphones are going to have to run around like mad because I'm going to ask those questions. But I'll repeat all the questions so you can all hear the questions. So one of our colleagues is saying it depends very much on the situation, and you're absolutely right. Of course it does. It depends on the patient, and as we've heard, they're not all the same. You know, they're not data sets. They're people. Some die quicker, some die slower, some behave in different ways. Pathology is mixed. Pathology can be very clean and pure. And yes, of course, it depends on your team. Depends on what tools you've got, it depends on what training you've got, it depends on what your service believes in, and it depends on where you are. Absolutely, that frames this whole thing. And yes, I'm in the mountains, but I could be in the city. And it does change what you do to a degree, but we have to ask ourselves that question, should it change what you do? And if so, how? Well, we'll come to that. So when he was pulling his mask off, gasping his last, and rolling his eyes back, and went all floppy, what is wrong with him? Do you still feel the same about what is wrong with him, or do you feel different about what is wrong with him? Someone put your hand up, and then I can try and see you. Someone said same-ish. Cool. Okay, so kind of the same, but not? That's a good answer. In fact, I was going to say, many of your answers to these questions, they might actually be the same, but possibly for different reasons. And I'll explain what I mean in a minute. But what do you mean by same-ish? So you still think he's in shock, and you still think he's going into cardiac arrest? So what's the ish? Okay, interesting. But something about it feels a little bit different, but you're not quite sure what. I know what you mean, I think. Okay, does anyone else? I mean, we can ask the question, is he arresting? Has he arrested? When does he arrest? When does this person arrest? That's a whole nother massive topic, but when does this person arrest? Rolled his eyes back, vomits, goes floppy. Is that an arrest or not? Yeah. I think so. I think it's either now or it's bloody soon. Okay. All right, does anyone want to put their hand up and volunteer any other answers to this? You don't. If you're bored and you want cheese, it's fine. But if someone puts their hand up, you can tell me what else you think. Go on, Wolf. Wow, man. Dude, that's a massive win. That is a massive win. You've just made his day, his year, his week. Oh man, I'm really happy for you, man. Okay, so in case anyone didn't hear, Wolf said that he's now feels that there is poor coronary flow, particularly maybe because of a low diastolic pressure, maybe even retrograde flow in diastole. So some weird in systole. See, even I can't get it right, man. Retrograde flow in systole and no flow in diastole, or very little flow, or poor flow. Yeah. So what should be happening to the heart, to summarize it for anyone who struggles like me with this stuff, in diastole, like we remember in our medical student days, blood flows forward because the pressure is low enough in the heart that blood can flow in the coronaries. But that all goes wrong when either there's a hole in the artery, or you've bled out, or even worse still, both. So something and I tell you how I sum this up is I sometimes get to patients, and you know, as well as going to patients, all of us as consultants run a thing called D&D, where we debrief cases, case after case after case. So we get a collective experience from our service. And we often hear about cases where they just seem to have died just a bit too quick. We're like, what? Why have they arrested so quick? And then when you say, where was the blood? Was the blood all over the floor? Was the blood in the chest? Was it a tamponade? Yeah, often all of that. But sometimes people say, no, I don't really get it. There wasn't enough blood. I can't understand why they arrested so quickly. And to me, that is some early signal of this thing that happens when there's a hole in a big artery. And the problem is not just the bleeding. The problem is the mechanics of the heart and the elasticity of the aorta and all this stuff that normally happens when your body has not been stabbed and has a hole in a big artery. Anyway, I'm lingering too long on the first question, but I think that's probably the most important question. What's wrong with him? We'll come back to that in just a second. What does he need? Has anyone changed their minds on what does he need? The first one, most of us said he's bleeding to death. The second one, most of us, I think, said he needs blood and he needs to get out of there and go to theatre. Someone's pointing at his chest. You want to open his chest? Okay. Okay, yeah, all right. Interesting. So you're saying he needs more blood than you thought he would? Which is interesting. We all need to talk in the pub, because I was asking the same question of Stacey, and actually some of us are getting different experiences with different volumes of blood, but I think probably as an overall picture, certainly from our group of patients, we feel like we're barely touching the sides with 3 or 4 units of blood. And it depends on your transfer time, doesn't it? Like Zane was mentioning 3 or 4 units of blood being a lot, but that's within the context of like 5 or 10 minutes to hospital. It's not enough time to get a lot of blood in. But the ones I think we really, really save take 8, 9, 10, 11, 12 units of blood pre-hospitally. You can make a bigger difference, let's put it that way, with that. Someone wants to open the chest. Anyone else change their mind about what they want to do? And you want to open the chest in the pub, you cool with that? Cool. Can he wait? Can he wait for you to open the chest when you get to hospital? I don't think so. But that's just me. Okay. Who? Go on, there's 2 hands up. The one on this side. Hello. Okay, good question. So the point is made of, I think you're saying he needs an ultrasound. Yeah? Okay. I'm not going to answer all these questions. I'm going to just chuck questions out, because these are things we all need to think about. And I personally agree. I don't think it tells you everything, and I think it can trick you. But yes, ultrasound, if there's time and if there's a question you need to answer, ultrasound can be very helpful. Another hand up. Go on. Yeah. Thanks, man. So, so someone's finally said Reboa, and but you've also said, and you're absolutely right, he first and foremost needs good wide-bore IV access and blood, right? I completely agree. And we have, on occasion, made the mistake of focusing on the complex interventions like Reboa and forgetting that we're not giving enough blood. We should make sure that someone's put a big fat line in and pummeling the blood in. And we now use really wide-bore subclavian lines that are quite scary to put in, but they're huge, and you can get a lot of blood through very quickly. Okay, moving on. Oh, hello. Yeah. Yes. Yes. Yeah, no, you shouldn't be sorry for saying anything. So what, in case anyone didn't hear, we're talking about a situation where you're out in the mountains miles away from blood and Reboa and doctors and trauma centres, and actually all you can do is get them to those things as quickly as possible. Absolutely, couldn't agree more. And actually, even in London, this is true. We're learning, we try not to just stay and do loads of stuff for ages and ages and ages. You know, it's easy to do that, but the concept of stay and play versus scoop and run, we need to move away from that. It should be scoop and play, you know, if you want to call it something. But you're right. From the moment you get injured, you need to be moving towards definitive hemorrhage control and cardiac resuscitation, whatever form that takes. And sometimes it just means getting the hell out of there as quick as you can. Absolutely right. But I guess it might, I don't know, it might change something about how you choose to travel or where you choose to travel to, maybe. Right, how long has he got? Does anyone feel any differently about how long he's got? He's rolling his eyes back. You've already mentioned you want to do a thoracotomy in the pub. Did you want to do a thoracotomy in the pub before or not? No. Okay, that's interesting. Okay, so you didn't want to do it before. And why? Do you think he's got less time than you thought? I just have to build this system that you all have. Yeah. Yeah, well, yeah, I guess and we're going to come in a minute to how different ways of approaching the same problem, but it catches me out because a lot of them do make it and a lot of them get to hospital, but every now and again one catches me out and they arrest way quicker than you thought and you just are completely caught off guard. And I think we have to try and think back to Robbie's pathophysiology and Zane's data and what these guys are telling us about the realities of it all and try and pick. It's really hard to do. You can't predict the future, but you have to try and pick who can't wait for their intervention, who needs it now. And also, coming back, I honestly think this is the most important question. What's wrong with him? If we're saying it's just hemorrhage, that's one thing. But if we're saying his heart is suffering and his heart is dying, it's not just suffering and struggling, it's dying, then for me, that changes the point at which I want to intervene. I don't want his heart to die irretrievably because I'm sick of getting him to hospital, high-fiving, and then finding out the next day he died on ITU, or the day after. Okay, does he need something extreme? We've kind of already touched on that. And someone put their hands up if you haven't changed your mind on whether he needs something extreme. That's a weird question, but has anyone not changed their mind on doing something extreme to this person? And if so, why not? Okay, that's cool, I guess. You're either bored or you're convinced, I'm not sure. And we'll come to the what then question. This is kind of where I was hoping we might end up at the end of this session. Whereas, as we said, rather than this is all hemorrhage, we might say, again, remember we said some of the answers might be the same, but for different reasons. Of course it's hemorrhage, right, that's happening to this person. But as a result, we are starting to think a massive part of the problem is that his heart is failing because of the hemorrhage and because of the hole in the normal structure of the big blood vessels. What does he need? Well, of course, he needs blood transfusion. Of course, he needs to get to hospital really quickly. And of course, he needs definitive control. But I'm starting to see them slightly differently because I'm now thinking I need to help this heart perfuse itself, and I need to help this heart survive this next half an hour, and then day, 2 days, 3 days. How long has he got? I wasn't sure if we would feel the same about the signs, the clinical signs. If you're thinking, I think you can only tell when you see a patient. You might start to think, oh my goodness, your heart's failing. I can tell. Honestly, I think you will occasionally see it, and it's interesting to observe, and it changes slightly what you do, and maybe your threshold for intervening changes. And the data, we've heard some new data that I don't think any of us have heard before, and I just want to quickly flick you onto this OBS monitor and ask you, do you see anything different now on this OBS monitor? I was a bit mean, I didn't tell you that, as Zane has mentioned, we've started invasively monitoring blood pressures, not because we want to waste time on seeing invasively monitoring blood pressures, but because we're moving towards endovascular resus. And the first step to putting a balloon in is putting in a big fat art line. And whether or not they get a balloon, a lot of sick trauma bleeding patients get an art line, and we're learning a lot from the physiology, right? So this was a patient who had a vascular injury, a large arterial injury. Do you see anything different in the monitoring? This is the invasive pressure. This is the non-invasive. No, hang on, have I got that the wrong way around? That's invasive, and that's non-invasive, right? So do you see anything quite dramatic there? No, this is P1. See, that says P2. That is an invasive arterial line blood pressure. Can you see anything interesting there? Look at the pulse pressure. It's ridiculous. 163 over 51. It's a massive wide pulse pressure. Now, this was a snapshot. You know, when I should have been resuscitating him, I was marveling at the monitor and took a picture of it. But I wasn't obviously going to sit there taking pictures of the monitor as it changed. But what this kid did was he would widen his pulse pressure. It would get wider and wider and wider and wider until the point where he suddenly braddied right down, which he's beginning to do here. And then he would tank his pressure, and he would only respond to massive transfusions of blood. I'll come on to why I didn't either open his chest or put a balloon in a minute, but it was a very good example of this pathophysiology we're talking about. And I just wanted to mention here something I'm going to mention later, which is, don't worry, not much later, but about supporting the heart. We'll come on to that at the end, right, which we are rapidly approaching, I promise you. Now, having said, right, Robbie's a lovely guy, yeah? And Robbie, this is pretend Robbie now, not real Robbie. Real Robbie's awesome. Pretend Robbie's a bit of a wrong 'un. And if you look at pretend Robbie's eyes, they're a bit shifty, man. Look at that. He's got shifty eyes. And you know why he's got shifty eyes, right? Because he didn't just stab one of us. He freaked out and he stabbed all 5 of the team. What the hell is with that, man? He stabbed everyone. And the reason he stabbed everyone is because he wanted to make a point to you all today and explain that there are different ways to treat this pathology. Have you ever heard of the expression, there's different ways to skin a cat? There's more than one way to skin a cat. That's what this stupid picture is meant to show. It's a ridiculous figure of speech, but there's more than one way to skin a cat. And I think it comes a little bit back to your question that, you know, we can't all open everyone's chests. We can't all put balloons into everyone. We haven't all got portable ECMO machines. We're all different services, and each situation is different. So I'm going to tell you about 5 cases in our system, all in London, in an urban centre where we've got all these capabilities, where we manage them all completely differently for different reasons. Briefly, and then we're done. And obviously I've had to anonymise them all, which is why Robbie theoretically stabbed our lovely team. First of our lovely team who gets stabbed is the lovely Chatters. Sorry, man. So John got stabbed in the groin, right? And these are all in the same physiological state that we've described. Like, you would call it agonal, peri-arrest, oh my God, they're going to die. You know, they look awful, and they've got all these signs of cardiac failure and shock, extreme hemorrhagic shock. And there are real cases, and all 5 of these cases survived. And if I'm honest, these, in much of the literature, would be described as people that have got an exceptionally high chance of death, if not definite chance of death, right? So briefly flicking through them, what John got was a zone 3 balloon. and I'm going to try and show you why each one got a different intervention. The reason John got a zone 3 balloon is because when the team got to him, yes, he looked awful. Yes, he looked like he was going to die. His wound was quite low, but it was causing dramatic external and internal blood loss. But he still had a pressure. Very low, like 50, I can't remember the exact numbers, 40, 50, but he had a blood pressure. He had complexes on his monitor, and the team decided, for this man, I'm going to put in a balloon. They ultrasound and they can see flow, so they believe that they can do the procedure. This is going to succeed. It happened to be a team that was a 3-person team. Sometimes we have 2, sometimes we have 3. And on that team, there were 2 doctors. So it meant one could focus on getting central access and giving blood and sedation and whatever else was needed, and the other one could just focus on the balloon. So there's loads of reasons why it felt right for that team to put in a balloon. They put it in zone 3, and it worked. Okay? And he survived and left hospital from this agonal state. Look at this lovely guy, man. Who would stab him? Pretend Robbie would stab him, all right? So pretend Robbie stabs him in the groin and the flank. And he's also agonal. Maybe you would say even more agonal. The description, this is someone Robbie actually treated, because he probably felt guilty about stabbing him. But he describes this guy as agonal and floppy and basically arresting. He started with a zone 3 balloon because the wound that he believed was killing them was down in the groin, and it didn't give any decent response. It wasn't enough. So he moved the balloon up to zone 1. He then even did external CPR because he was arresting. And with that, plus blood volume, he got an output back. And this is a man who was in cardiac arrest from exsanguinating trauma, got a big volume of blood, balloon in zone 1, and external CPR, and he survived and left hospital and did ultimately well. This guy got a thoracotomy, not just because he's a surgeon, and that's what he would have chosen for himself, but because he was shot. The real case was shot. I know we said it was all stabbings, but he was shot through the abdomen, lower abdomen, right, and had actually kind of hit the iliacs. And the reason he got a thoracotomy was because a number of reasons, factors, small cramped environment in a little flat, a clinician who's done, 30 years now of HEMS, and it knows how to do a very, very quick thoracotomy, a situation where the complexes on the monitor were still quite fast and narrow and looking actually quite healthy, even though there was no palpable pulse. He looked like he was dead. I've seen a head cam video. He looks like he's dead, but he's got narrow complex tachycardia. And I asked him, why did you do a thoracotomy, not a balloon? He just said, I just knew I was going to be much quicker in the chest with a thoracotomy. I didn't believe I'd get a balloon in, and certainly not quick enough. So he did a left lateral just to grab the aorta, to reperfuse the coronaries, and reduce hemorrhage, and allow him to resuscitate the patient, right? And he did really well. He survived and did well. This guy, again, I mean, who'd want to stab him? I wouldn't want to stab him, man. If he got me with one of those right hooks, I'd be dead. But he gets a clamshell, and the reason he gets a clamshell, he's also actually stabbed in the groin, very similar to some of the earlier ones you've heard. But he, not only does he not have a pulse and he looks like pretty much dead, he's got a really slow, unhealthy-looking rhythm. I can't tell you the exact complexes, but it looked slow and unhealthy. And the team A didn't believe they would get in quick enough with a balloon. It was a smaller team. It was night time, so there's less resource there. And they just felt like he was going to need internal cardiac massage as well as hand on the aorta. So they chose to do a clamshell rather than left lateral. So my point is there's different ways of approaching even just aortic occlusion. This ridiculous individual was stabbed in the upper abdomen. And this is, it wasn't me, obviously. It was a young lad who was actually 14, given as 12. We were told he was 12, and he looked even smaller than that. He was tiny. And I looked at him and thought, oh my God, you look sick, but right now you're not quite sick enough. But we did put in a full French art line, and I hoped to God that I wouldn't have to put a balloon in. Now, I'm the lead for training for Roboa, and I still didn't want to put a balloon in him because he was so small. It was going to be a struggle to fit the sheath into his tiny femoral artery. And all I'll say about him is, ultimately, he survived, right? But he was the one who had that monitor that I keep showing you, and he scared the absolute living daylights out of me repeatedly because he kept trying to die. And I think I got away with it, and I was kind of forced into not putting a balloon into him because of his size, but it shows us that there's another way of managing this problem. And I think the only reason he survived was because we were able to give him very large volumes of blood. In the 10 or 15 minutes it took to get into hospital, he had about 8 units of blood, and a lot more on arrival in resus. Went up to theatre very, very quickly. He transected his splenic artery. It squirted all over the trauma surgeon who was trying to fix it, and he survived, but I think only because of a very, very big blood transfusion, aggressive. So I am going to wrap up now and say that it feels like we're not sure if we've changed our minds or not, but I think the point is we need to think really a bit harder about what the real problem is. And only when we really understand, which we still don't, we're still learning, we still need to do more research, we need to ask more questions about what the real problem is, why these people really die, can we then come up with the solutions, right? And I think it's probably not just this. Sadly, it's much more complicated than this. And I mean, it's not just about filling the bucket back up with blood. If it was, that would work for everyone. We just need bigger lines of more blood. But for some people, it doesn't work. It's not quite enough. It's still really important. And whether that means you get them to the blood quicker or whether it means you give them the blood quicker, it's fundamentally important. But it's not enough for everyone. And we have to appreciate that there is more, that the body is amazing, and there's complex mechanics going on that we don't even appreciate to do with the pump and the elasticity of the arteries. And when you put a hole in that vessel, it knackers the mechanics. And we must remember how sensitive this pump is to ischemia. And we do not understand, we're only just starting to understand what's going on in the coronaries. And we have to look after this pump, not just later at this stage when we're thinking about ECMO, but right from the very beginning, we have to look after this pump early, from the very outset. It's very sensitive, and once it suffers damage, it's often irreversible damage. And yes, when we think about cardiovascular support, we all think of ECMO. ECMO is really cool, it's amazing, and everyone's talking about it, but you know, you've got to get people to a state where they can actually be put onto ECMO first, and then we have to appreciate that if you get them through the first hour or two, the next 2 or 3 days are going to be very rocky. And it's not, as I often thought, just for their livers and their kidneys and, you know, all the rest of, and their brains. It's for their heart as well. Remember Zane's graph with the big, massive spike in cardiac failure in those that die. And if I was to try and make Ross proud of me, I might say, just remember one slide of everything that we talked about, and that's this. I actually wanted us all to wear these T-shirts, but no one thought it was cool. So we didn't. But just remember that one picture, right? And I mean this heart. We're learning so much about what happens to the heart and what we need to do to treat the heart when someone is exsanguinating and when someone is injured. And I guess one other take home is watch out when you're in the pub. Don't get stabbed by anyone. Thank you very, very much for having us all here.
Thank you very much.
If you guys want to, we can disappear, or if there are any questions, we can take some questions for the team.
Hey, awesome presentation, team. I just wanted to be your devil's advocate since it seemed like no one else was willing to jump in there. So, first question real quick. In that 1 minute that goes on between when you arrive and when you do the thoracotomy, like what is there any sort of diagnostic procedure going on, or is it just like no pulse, time to cut? Like what is going on there?
I'll tell you my answer, and then I'll pass you on to Zane. For me, in many cases, pretty much nothing, because we've been given such a useful SOP, which is so standardized, and it says if you have penetrating trauma between the base of the neck and the groin, and you arrest. Now, you used to talk about the precardial, the front of the chest and the chest trauma, but essentially, if you arrest from penetrating injury in your torso, and it's within 10 minutes, you open the chest. And what that does is it takes the thinking out of it, it takes the dithering out of it, and it helps us speed up the thoracotomy to get closer to the survivors that Zane's described. It's still frustrating that it even takes a minute, because just, I don't know where you get that data from, and you'll tell us now, but physically it takes time to arrive. How long has he been in arrest for? Someone says 20 minutes, someone says 5 minutes, someone says 15 minutes, someone shouts at someone else, and you just think, look, he's potentially a goer. You get down on your knees, you open the chest, and that process tends to take about a minute. But for me, there's very little thinking. It's different if someone hasn't yet arrested. That's very, very different, and that's a harder decision to make. And we're still learning when you should intervene before someone has fully, well, not fully arrested, but let's say gone asystolic. How you intervene in that little sweet spot. I'm going to give you to Zane.
I think Sammy's covered most of it, but what makes that, I mean, a minute isn't as short as you think. It's quite long, actually, to stand for a minute looking at someone who's in arrest. But what affects that data is that so many of our patients are in full arrest when we arrive. So, because if, the witness to arrest, there's a lot more decision-making that needs to go on, or you've already treating them in that. Our SOP is looking for tamponade, and our procedure is designed to treat tamponade. So if they've got a injury, and we're lucky compared to America that most of our injuries are stabs. So if there's a stab in the chest or epigastrium, we have a very high probability of tamponade. It's about 40% chance. And because it's got such a good survival, we don't want the clinical teams to get bogged down in the decision making. They just have to go make a decision, is the patient in arrest or not? And then are they within a survivable window or not? And that's why it's quite quick.
Basically, I was wondering if you did an ultrasound to look for the tamponade or not, but it sounds like no.
Yeah, so on that, if it's blunt trauma, because the probability of tamponade is much lower, it's not naught. In our series, it was about 6%. Or if the stab is, in a vicinity you're not sure, like the upper abdomen, then we do want the clinicians to get more clinical information. That might be from an ultrasound. So we do have ultrasound, we do use it for that, but I think it's very helpful in the blunt ones.
So you showed a couple of patients that had a stab wound in compressible hemorrhage areas. I think it was the thigh and the neck. And I was curious, I know we had some studies out of shock trauma where they looked at closed cardiac massage during resuscitation, in relation to Reboa, thinking that if you do the Reboa, you don't necessarily need to do the thoracotomy just for open heart massage, because they were looking at the cardiac output during closed cardiac massage versus open cardiac massage to try to see if there was any advantage to just doing open cardiac massage. And in that study, it didn't seem like there was. So I'm curious. And so we had kind of taken the route of, like if it was not torso hemorrhage where it was compressible, doing blood and closed cardiac massage if they needed cardiac massage or just blood.
Yep, we take a similar line, but we do feel the aortic occlusion is really important in that end stage shock, just to help that heart, give you a few more minutes to get the blood in, avoid a complete stopping of the heart, because what our experience is, once they're in asystole, there's no coming back from it. So you just needed sometimes a few minutes to get the central line in, to get 2 or 3 units of blood in for it to start having an effect. But in the lower ones, we're moving towards wanting to do the left laterals rather than the clamshells and get in before the heart stops, but otherwise doing a Reboa and external massage is completely acceptable.
I'll get the rest of the questions in the bar. I think everyone's ready to go.
Thank you. Any other questions? Over here. I'll run. I didn't do enough skiing.
Yeah, ultrasound guy here again. Zane, your data showed like there is some dependence on whether there is cardiac activity or not. And you said just in one sentence, yeah, that might be an ECG or ultrasound. And so I spent the nights before the conference just taking these things different. Did you do any analyze on cardiac mechanical standstill versus some contractility, or is this simply, doesn't it matter in trauma?
So we looked at the ECG rhythm strips at about before the thoracotomy was done, or what the clinicians saw, or what the heart was doing when the chest was opened. I'm not fully convinced by. I think if you've got electrical activity on the ECG, you'll probably have some motion on the ultrasound and what the disconnect is. But we didn't look at that specifically, and the reason I looked at ECG with this data was just because it always gives you the answer, and it's usually been done. We just don't take notice of it in the heat of the moment. Whereas ultrasound, I think, is as good in the right hands, but it is operator dependent. So we need to make these decisions quick, and I wanted to give some other options other than something that might take a few more minutes to get right, especially some people in our service don't do ultrasound all the time. So hope that helps some of that answer.
Yeah, it does. Gives me some peace of mind.
Just to add to that, I would say I love ultrasound. I use ultrasound a lot, and I still don't use it in those situations because I find it takes me too long. I know there's a high chance I won't get the answer I need, and I'm so conscious that every second that goes by, there's a higher chance of death. If I know I need to get in the chest, I just need to get in the chest. Or put a balloon in, or do whatever extreme measure I need, and sometimes there isn't time for ultrasound, I think.
Yeah, so again, back to the Reboa and thoracotomy issue. I don't know if it's an issue, but because I see the Reboa the same way as your villain over there. Maybe it's because I work in the same field, but as more of a cardiac support measure, more than a bleeding stopping measure. And so if you have stabbing violence below the chest, if I can then put a Reboa in to do the same thing as an manual aortic compression, would there be any other reasons to open the chest? I heard about the manual massage, obviously, but why would you go for the thoracotomy otherwise in that situation?
Well, I think for me, and I think I speak for our service in saying that one of the reasons we've venturing on this endovascular route is to try and avoid a thoracotomy that a patient might not need. You can't always do that, and the obvious ones for me, so Robbie and I debrief every single Reboa case and every single attempted Reboa case, and there's a reasonably high incidence of inability to get into the vessel. When these people are this shocked, and you've got this little time and the team are this stressed, sometimes you can't get into the vessel to deploy the balloon, and that for me is the main reason. Robbie, tell us what you think.
Yeah, no, I mean, I would agree. There's a definite shift away. I mean, the key thing is treating the pathophysiological problem, which is getting, coronary perfusion going again. So if you can do that quickly enough in someone who's arrested with Reboa, I definitely advocate for that. And we've got 3 patients now who, in our series, who've exsanguinated, had bradyarrhythmias, pulseless, who, with a combination of zone 1 Reboa, preload restoration and external massage, and small amounts of adrenaline, epinephrine, I've got ROSC and gone on to survive. So yeah, I think that's definitely the way we're heading. But you've got to remember the series we're talking about is is over 25 years before Reboa existed. And if you can't do Reboa quickly, though, I think a left lateral thoracotomy, the key principle is restoring coronary perfusion and doing it quickly. Yeah.
One more question, and I think we ought to release you to the bar to carry on after this.
And I was just wondering, what would you say is the loss in efficiency if you're unable to give blood in all these invasive techniques? Because for our region, it's really, really difficult to get this amount of blood you've been talking about. Like, would you make sense if we're unable to give blood? Are those meaningful interventions still? If you might solve the problem, but you can't really resuscitate them with blood. Because I think that's one of the important factors I took from this.
Yeah, can I, Zane looks like he's itching to answer, but can I just ask you, tell me, to put us in context, why, what's your limitation? Is it how much blood you carry, or is it difficulty in getting access, or is it, what's the limitation with giving blood?
The limitation for us is like German regulation, and it's really tough discussion with our blood bank to get blood in a preclinical setting.
Yeah, okay. And I'm sure that's something that many, many services face, and we have struggled over the years to get where we are. Go on, Zane, do you want to?
We can all probably... we've had a lot of changes in our service over the last 10 years. I mean, Robbie and I introduced Reboa in 2012, and we only introduced blood a few years after that. And when we did the initial work on the Reboa, and we worked out kind of how many patients we might need to do Reboa on, our calculations showed a lot more than what we do now, and for many other reasons. But essentially, blood, in my opinion, has been far more effective than I ever thought it would have been. It's really made a massive dent in needing things like Reboa on our service. We give about 200 or just over 200 blood transfusions a year, and we do Reboa now about 5 or 6 times a year. And the blood transfusion is why our numbers of thoracotomies and Reboas have just dropped through the floor. So I think it's very effective. I think, judging from Stacey's data, they think it's effective, but it isn't clearly coming through in the studies, and I think a lot of that is about selecting the right patients, because it can only obviously work in these people who are about to die from exsanguination, but if you cast too wide a net, you just dilute out the effect in the research. So that's my views. We can chat more. I don't know if any of the other guys have views on it. But
just to close, I guess I would say if you're limited in whatever aspect it is, whether it's carrying blood or carrying a balloon or doing thoracotomies or, you know, the makeup of your team, the main thing to take away is what the pathophysiology is that we're seeing, what your patient cohort is, and how many of your patients die before you even get to them or before they come to your hospital. And that's the starting point. That has to be the starting point. You then have to decide, based on what I've got, what do I do? And it often is something quite extreme. It might involve extreme surgery, pre-hospitally, or an ED, but it has to be based on who's dying. Do we want to make a change to that? And if we do, we have to work out how to either change our team, our process, or our interventions. Thank you.
Cool.
We'll
Thank
talk
you.
more in the pub.
Yeah, we've massively overrun, but thank you so much for staying and your engagement. Let's go to the bar and carry on these discussions. Thanks, guys.